Influenza remains one of the most studied infectious diseases because of its global burden and capacity for rapid mutation. This presentation provides a comprehensive overview of its structure, biology, and clinical implications, highlighting the critical insights provided by Danji et al. 2020. By the end, you'll have an integrated understanding of influenza's biology and how current treatments and vaccines aim to control it. Let's start with some history. While we commonly call it the flu, the virus has 4 types: A, B, C, and D. The first human isolation of influenza occurred in 1933 by Smith, Andrews, and Laidlaw, relatively recent in the grand scheme of microbiology. Interestingly, swine influenza was actually isolated 2 years earlier by Shope in 1931, which gave us crucial insights into the virus. But influenza isn't a modern disease. Historical records describe influenza-like outbreaks dating back to the 1500s, though we couldn't confirm these were truly influenza until we had the tools to isolate and identify the virus. The most devastating pandemic, of course, was the 1918 Spanish flu, located here on our timeline. It killed an estimated 50 million people worldwide, more than World War I itself. This historical context reminds us that influenza has been shaping human history for centuries and continues to pose a significant threat today. Again, our image here shows us the origin of the H1N1 virus with the Spanish flu and how it has changed through time. Now let's look at how influenza is classified. All influenza viruses belong to the family Orthomyxoviridae, but they're not all created equal. Influenza A is the most concerning for pandemic potential. It has an incredible diversity: 18 different hemagglutinin subtypes and 11 neuraminidase subtypes. This is why you'll hear names like H1N1 or H3N2. You see them labeled here under the pictures. These numbers refer to which HA and NA proteins the virus carries. This diversity exists because influenza A infects multiple species, including birds, pigs, and even humans. That's us down here. It allows for genetic mixing. Influenza B is exclusively a human pathogen and has 2 lineages, Victoria and Yamagata. While it causes seasonal epidemics, it doesn't have the pandemic potential of influenza A because it lacks that animal reservoir. Influenza C and D are the minor players here. Type C causes mild respiratory illnesses, mainly in children, while Type D primarily infects cattle and isn't known to cause human disease. For the rest of this presentation, we'll focus primarily on influenza A and B, as these are the clinically significant types of human health. So again, you can see how it started, virus A, and as it's gone through reassortment down to humans. Here's where influenza gets really interesting from a molecular standpoint. The virus is enveloped, meaning it has a lipid membrane stolen from the host cell. Studied on this surface are 2 critical proteins, hemagglutinin, or HA, that's this one here, which binds to host cells to initiate infection, and neuraminidase, or NA, this one here, which cleaves sialic acid to release new viral particles. Inside we have 8 segments of negative sense single-stranded RNA. This segmented genome is influenza's secret weapon. When 2 different influenza viruses infect the same cell, these segments can mix and match, a process called reassortment. This leads to antigenetic shift, where a completely new virus emerges, potentially causing a pandemic because no one has immunity to this novel combination. The virus also encodes several internal proteins, like M1, provides structural support. M2 is an ion channel crucial for uncoding. NP protects the RNA, and PA, PB1, and PB2 form the viral polymerase complex up here. One unique feature, unlike most RNA viruses that replicate in cytoplasm, influenza replicates in the nucleus. This is unusual and has important implications for how we can target the virus therapeutically. Let's walk through how influenza hijacks our cells. First, the HA protein binds to sialic acid receptors on respiratory epithelial cells. The virus is then engulfed by endocytosis. As the endosome acidifies, the M2 ion channel allows proteins in, triggering a conformational change in HA that causes membrane fusion. Once the viral RNA enters the cytoplasm, It's transported to the nucleus down here. Remember, that is the unusual feature that I mentioned on the previous slide. Inside the nucleus, the viral polymerase performs something called cap snatching. Essentially, it steals the 5' from host cell mRNA to prime its own viral RNA synthesis. This is both clever and malicious. It shuts down host protein synthesis while promoting viral replication. Here's the replication. When new viral RNA segments are then exported to the cytoplasm, where viral proteins are made, everything assembles just beneath the cell membrane and new virons bud off. This is where Na becomes critical. It cleaves sialic acid residues, preventing new viruses from sticking to the cell they just exited. Without Na, viruses would clump together on the cell surface, which is why Na inhibitors like Tamiflu are so effective. So what happens when you get the flu? Influenza primarily targets respiratory epithelial cells. The virus itself damages these cells, causing cell death and sloughing the respiratory lining. But much of what we experience as flu symptoms actually comes from our own immune response. The infected cells and immune cells release massive amounts of cytokines, interferon, tumor necrosis factor, and interleukins. The cytokine storm is responsible for the fever, body aches, fatigue, and general misery that characterize influenza. It's also why the flu feels so much worse than a common cold. Complications can be serious. Viral pneumonia can progress to acute respiratory distress syndrome, or ARDS, where fluid fills the lungs. Additionally, the damage to the respiratory tract makes secondary bacterial infections common, particularly bacterial pneumonia from Streptococcus pneumoniae or Staphylococcus aureus. As this image illustrates, certain populations are at particularly high risk, so infants under 6, that's over here on this side of the graph. Those immune systems are still developing. Elderly individuals with waning immunity, so those are over here. So we can see on the mortality, the elderly are the highest. Pregnant women due to immune system changes, and anyone with chronic conditions like asthma, diabetes, or heart disease. This risk stratification is crucial for targeting interventions. Here we can see that morbidity is the number of infections, so higher numbers in the younger populations, lower numbers here. And then mortality is death, so we see higher mortality in the 65 plus age group. Let's zoom out and look at the big picture. According to the WHO, influenza causes approximately 1 billion infections worldwide each year, with around 650,000 deaths. These aren't just numbers, these represent real people, real families affected by this disease. Transmission occurs through respiratory droplets when infected people cough or sneeze, but also through smaller aerosols that can hang in the air and through contact with contaminated surfaces. The incubation period is relatively short, 1 to 4 days, and people are contagious from about 1 day before symptoms appear until about 5 to 7 days after. Influenza A's natural reservoirs are aquatic birds, which are the ultimate source of all influenza A viruses. Pigs serve as mixing vessels because they have receptors for both avian and human influenza viruses, allowing reassortment to occur. This is why pig farms are monitored so closely for pandemic potential. This CDC image shows the characteristic seasonality we see in temperate regions. Why winter peaks? Well, several factors. People spend more time indoors in close contact, lower humidity allows viral particles to remain suspended longer, and cold air may compromise our respiratory defenses. Interestingly, in tropical regions, influenza can circulate year-round with less predictable patterns. Diagnosis has two main approaches, each with trade-offs. Rapid antigen tests can give results in 15 minutes at the bedside, but they're only about 50 to 70% sensitive, meaning they miss a lot of cases. RT-PCR is the gold standard with over 95% sensitivity and specificity, but takes longer and requires a lab. For most healthy people with uncomplicated flu, treatment is supportive. Rest, fluids, fever reducers. The body will clear the infection on its own within a week or so. However, for high-risk patients or those with severe symptoms, we have more aggressive options. Antiviral medications if started within 48 hours, supplemental oxygen for respiratory distress, and sometimes mechanical ventilation for severe cases. One important consideration is bacterial co-infection. If a patient isn't improving or suddenly worsens after a few days, we need to think about secondary bacterial pneumonia and consider antibiotics. This image illustrates the clinical decision-making process clinicians use to determine appropriate management strategies. So you can see the effectiveness of the vaccines through the years. So 2010, 2011, we had 60% effectiveness. 2014 and 15, only 19. Our antiviral arsenal has evolved significantly. The most commonly used drugs today are neuraminidase inhibitors, oseltamivir, which is known as Tamiflu, and zanamivir or Relenza. These work by blocking Na, preventing new viral particles from escaping the infected cell. They need to be started within 48 hours of symptom onset to be effective, and they can reduce symptom duration by about 1 day and decrease complications. M2 blockers like amanidyne and rimanidyne were once our first-line drugs, but widespread resistance has made them essentially obsolete. Over 99% of circulating strains are now resistant to these medications, so we don't recommend them anymore. The newer kid on the block is baloxavir marboxil, a polymerase inhibitor that blocks viral replication with a single dose. It's showing promise, though resistance can develop. They're also investigating host-targeted strategies, drugs that modify host cell processes the virus depends on, rather than targeting the virus directly. The advantage here is that the virus can't mutate its way around these drugs as easily. Looking forward, combination therapies may give us better outcomes, similar to what we have done with HIV treatment. Vaccines remain our best tool for prevention, and vaccine technology is evolving rapidly. Traditional inactivated vaccines have served us well, but they have limitations. We have to predict months in advance which strains will circulate, and sometimes they get it wrong. Newer platforms are addressing these limitations. Recombinant vaccines use genetic engineering to produce just the HA protein, allowing faster egg-free production. That is on this path here. This is the egg side. Virus-like particles, or VLPs, mimic the virus structure without containing genetic material, triggering robust immune responses. The mRNA platform, which proved itself during COVID-19, is being applied to influenza. Early trials show high neutralizing antibody titers, and the platform allows extremely rapid vaccine updates when strains change. We can potentially go from identifying a new strain to producing a vaccine in weeks rather than months. The Holy Grail is a universal influenza vaccine that protects against all strains, eliminating the need for annual shots. Researchers are targeting conserved parts of the virus that don't mutate, like the HA stalk rather than the head, or internal proteins like M2 and NP. While they're not there yet, progress is encouraging. A universal vaccine would be transformative for global health. So again, there's different steps here for how they can produce the vaccines. One going from recombinant HA, we have cell-based and egg-based. Prevention operates on multiple levels. At the individual level, annual vaccination is recommended for anyone over 6 months old. Yes, vaccine effectiveness varies, typically 40 to 60%, depending on how well the vaccine matches circulating strains. But even when it's not a perfect match, vaccination reduces severity and complications. Beyond vaccination, basic public health measures matter, like hand hygiene, respiratory etiquette, and staying home when sick. During flu season, masks can reduce transmission, especially in healthcare settings or for high-risk individuals. Social distancing, while we're all tired of hearing about it after COVID, does work for the flu as well. On a global scale, surveillance is critical. The WHO coordinates a network of laboratories in over 100 countries that continuously monitors circulating strains. This data informs vaccine composition each year for both the northern and southern hemisphere. When novel strains emerge with pandemic potential, like H5N1 bird flu or H7N9, the surveillance system triggers rapid response protocols. Pandemic preparedness includes stockpiling antivirals, having surge capacity plans for hospitals, and developing rapid response vaccine platforms. The COVID-19 pandemic actually taught us valuable lessons we can apply to influenza preparedness. Let's bring this all together. Influenza's success as a pathogen comes down to its genetic flexibility. That segmented genome allows reassortment, creating novel strains that can spark pandemics. Meanwhile, point mutations cause antigenic drifts, necessitating annual vaccine updates. It's a moving target, and that's what makes it so challenging. The disease we experience is a combination of direct viral damage and our immune system's response. Understanding this helps explain why immunomodulatory therapies might be beneficial in severe cases. We do have effective tools, vaccines that prevent millions of infections each year, and antivirals that reduce severity when used appropriately. But we're not standing still. Emerging technologies, particularly mRNA platforms and universal vaccine research, promise to give us broader, more durable protection. The future of influenza control likely involves multiple strategies: better vaccines, more effective antivirals, improved surveillance, and maybe even interventions we haven't thought of yet. Thank you for your attention. Here's my reference list for this presentation. I hope this gives you a deeper appreciation for influenza, not just as an annual inconvenience, but as a sophisticated pathogen that continues to challenge us scientifically and clinically.